Moving on to the prostaglandin analogs. This is a well-known class and is often the first therapy or topical glaucoma therapy prescribed to patients because of its excellent efficacy and easy dosing. All of these drops, as you can see in the pictures there, have teal or turquoise tops, and they all work to increase uveoscleral outflow through the stimulation of PGF2 alpha receptors, which lead to ciliary muscle relaxation. Now, several other possible mechanisms of action have been proposed as well, including remodeling of the extracellular matrix of the ciliary body, which leads to widening of connective tissue spaces and increased permeability of the tissues. And some studies have suggested that PGAs also increase trabecular outflow through an increase in matrix metalloproteinases, which subsequently lead to extracellular matrix remodeling within the TM. Overall, prostaglandin analogs, or PGAs, have great IOP lowering ability at about 20 to 40%. That, in combination with the very convenient once daily dosing, make this a really good choice and a common choice for the first line therapy for patients. As you can see in the figure at the bottom of the page, another benefit of prostaglandin analogs is that they have good 24-hour pressure lowering, including good efficacy at nighttime or during sleep when pressure tends to be the highest. This figure at the bottom compares latanoprostene bunod, which are the triangles, with timolol, or the filled-in squares. And as you can see, the latanoprostene bunod had a significantly greater pressure-lowering ability at night when compared to timolol. A list of the PGAs that we have available in the United States right now is on the right of this slide with both the generic and the brand names. A few important differences to note here, that one of which is that bimatoprost or Lumigan is actually a prodrug called a Prostamide. Travoprost or Travatan is BAK free, but it's not preservative free. It has an alternative preservative called Softsia in it. Zioptin or Tafluprost, on the other hand, is truly preservative-free and as such comes in individually dosed peel packs. And then the newest to the market, Zelpros, is a BAK-free formulation as well, but uniquely it is delivered in a microemulsion and therefore it's marketed as better for ocular surface and dry eye patients. Vyzulta, or latanoprostene bunod, is a relatively new and unique agent that's available. It is a combination of both a prostaglandin analog and a nitric oxide component. And because of this, it works on both the traditional and the non-traditional outflow systems. So just like all prostaglandin analogs, it increases uveoscleral outflow, but that nitric oxide component also causes trabecular relaxation, therefore increasing trabecular outflow in addition to uveoscleral outflow. In the Voyager study, which compared Vyzulta, or latanoprostene bunod, with latanoprost, Vyzulta achieved 1 millimeter of mercury additional pressure lowering when compared to that traditional prostaglandin analog. And in the study, 70% of patients on Vyzulta achieved a pressure of less than or equal to 18 millimeters of mercury, compared to only 50% on latanoprost. Now, the biggest question is probably, where does this fit into the treatment algorithm? And a lot of people don't know. But keep in mind, you could potentially get a little bit of additional pressure lowering with Vyzulta when compared to a traditional prostaglandin analog, so it might be worth a try. Prostaglandin analogs have some unique side effects. They can lead to both skin and iris hyperpigmentation, and it's important to note that the iris changes, if they occur, are irreversible and are more common to occur in green eyes, whereas the skin changes are reversible with cessation of the medication. PGAs can also cause eyelash growth, hyperemia, worsening of dry eye symptoms, and as this photo in the top right corner shows, orbital fat atrophy, which manifests as superior sulcus deepening, often called prostaglandin-associated periorbitopathy. This is one of the reasons that unilateral PGA use should be used with caution, as it can lead to significant facial asymmetry if this were to occur. Caution should also be exercised when considering using PGAs in patients with either a history of cystoid macular edema or those with a history of ocular herpes simplex virus, as it can be associated with recurrence. Moving on to alpha agonists. Alpha agonists are a class of medication which decrease aqueous production, and they do so in a few different ways. They all inhibit or decrease adenylate cyclase, which is the enzyme which turns ATP into CAMP, and therefore they reduce CAMP. They also cause vasoconstriction of the blood vessels running to the ciliary body, both of which lead to decreased production of aqueous. There are also theories that they increase uveoscleral outflow with long-term use. Now, all alpha agonists in general have a purple top, as you can see in the bottom right two photos. However, some iopidine, which is also known as aproclonidine, does come in individual peel packs, and so those don't have a purple top. You can divide alpha agonists into non-selective agonists and alpha-2 selective agonists. Brimonidine and aproclonidine are the two most commonly used alpha agonists, and both are alpha-2 selective. Alphagan, or brimonidine, is more selective for those alpha-2 receptors than aproclonidine is. A unique feature of aproclonidine or iopidine is that it's often not used for long-term treatment due to two factors. One, it has a high rate of blepharoconjunctivitis, and two is tachyphylaxis, or a decrease in efficacy with chronic use. The non-selective alpha agonists are epinephrine and dipivefrin, neither of which are commonly used anymore. There are multiple formulations of brimonidine, commonly referred to as Alphagan, on the market. There is a 0.1% formulation, a 0.15% formulation, and a 0.2% formulation. Alphagan P is a BAK free alternative, which has an alternate preservative in it called purite. But again, it's important to note that it is BAK free, not preservative free. It just has an alternate preservative in it that tends to be less irritating to the ocular surface. The peak effect of alpha agonists is often seen approximately 1 to 2 hours after instillation, which makes them a great medication option to prevent pressure spikes after laser procedures, such as LPI, or laser peripheral iridotomy, or SLT, selective laser trabeculoplasty. On average, alpha agonists have about 14 to 26% pressure lowering from baseline. A very important feature of alpha agonists is that they are contraindicated, strictly contraindicated for use in children under the age of 6 or 7. And that is because it leads to central nervous system depression, apnea, and seizures. It is, however, the only glaucoma drop that is category B in pregnancy. The rest of the glaucoma drops are category C, or you have Repressa, which we don't know which category that is yet. Now, even though it's category B for use in pregnancy, it can be excreted in breast milk. And as mentioned previously, it's not for use in children. Therefore, you need to stop this medication ideally several months before the patient delivers so that it can be washed out of their system, because it cannot be used or should not be used in breastfeeding mothers. Other side effects or unique effects associated with alpha agonists are that it can cause dry mouth. It does have a high rate of ocular surface allergy, which commonly presents as a follicular conjunctivitis and eye redness. It's also been associated with lethargy, headache, meiosis, and blanching of the conjunctival vessels, and it's contraindicated in patients on certain antidepressants such as MAOIs or TCAs. Moving on now to the carbonic anhydrase inhibitors, or CAIs. CAIs come in both a topical formulation and a systemic formulation, which we will touch on later. The topical formulations all have orange tops, as you can see in the two photos at the bottom of the slide here, and these decrease aqueous production through inhibition of the carbonic anhydrase enzyme located in the non-pigmented ciliary epithelium. This inhibition of carbonic anhydrase leads to decreased bicarbonate formation, which leads to a relative acidosis, which therefore interferes with the sodium-potassium pump, all of which leads to decreased production of aqueous fluid. All carbonic anhydrase inhibitors are sulfa derivatives, and even though the cross-reactivity is low, they can lead to severe allergic reactions in patients who are sulfa allergic, and therefore should be used with extreme caution. The two topical formulations that we have are dorzolamide, also known as Trusopt, and brinzolamide, also known as Azopt. Both dorzolamide and brinzolamide have approximately 20% pressure lowering from baseline. An interesting distinction between dorzolamide and brinzolamide is that brinzolamide is a suspension, whereas dorzolamide is a solution. There are two forms of systemic medications, acetazolamide and methazolamide, both of which will be discussed later. Side effects of topical CAIs include burning and stinging upon instillation, allergy or worsening of ocular surface disease. Patients sometimes complain of a bitter or metallic aftertaste, and then they can be associated with paresthesias or tingling in fingertips, weight loss, and fatigue, though those three are rare and are more commonly associated with the systemic formulations. The topical drops can also be toxic to the corneal epithelium and endothelium, which can lead to corneal decompensation, especially in patients who are predisposed to endothelial dysfunction. A unique side effect of brinzolamide, again because it's a suspension, is that it leads to blurred vision after instillation, which can take several minutes to clear. Also, because it's a suspension, it should be shaken before use.